Hi, good morning, everyone. Thank you for joining today's HCN annual training webinar on UDS 2020. This session will cover information about the UDS clinical reports. For those of you who may not know me, my name is Sue Cervical, and I am the manager of the system optimization team here at Health Choice Network. I've been with the network for about 14 years, holding different roles, but what remains the same is of my involvement in UDS and supporting our health centers to obtain accurate data from the different reporting tools that are available. So just a bit of housekeeping rules here for this session. So the session is in listen-only mode right now. If you do have any questions, please feel free to just submit them or enter them into the question box. Questions are definitely welcome. If there's time at the end, then I will go ahead and unmute everyone, unmute the session, and then you guys can, freely ask questions if you wish. There are 3 handouts available if you just in the GoToWebinar control panel. The 3 handouts, I would suggest that you download them. One of them is the presentation slide deck that you have a copy of. And then the 2 other documents are just Greenway documents. One is the PA 1215 release notes. And the other one is the UDS, it's a user's guide for UDS 2020 using Practice Analytics 1215. So again, questions are appreciated and encouraged. What we will do is compile all of the questions that have been asked in the webinar series into one FAQ document, and that will be provided afterwards along with the link to the recorded sessions. Okay, so on to the agenda. So I'll start with going over just highlights of practice analytics in relation to UDS readiness. And then we'll talk about what's new for UDS 2020, and then the approved changes for 2021. And then we're going to go over setup and workflow of the clinical tables of 6A, 6B, and 7. And this is more of workflows relating to energy and and how the numerator criteria and denominator criteria would be met with in the different areas of the EHR. And then last are just validation tips that I would like to share with you. This is more like strategies to help with reporting ease and just things that you should know as far as using PA and how and the data that you see using it. Okay, so starting with the practice analytics overview. So as you may be aware, practice analytics, your practice analytics will be upgraded during this month, and this is in preparation for UDS reporting. So version 1215 is for UDS 2020. The version that we've been using is updated for, was for 2019. So all of the measures have been updated as far as value sets for 2020 reporting. Now, after the upgrade, you will see the 3 new measures that have been added for 2020 reporting: the breast cancer screening, HIV screening, depression remission at 12 months. And then a lot of updates have been added to table 6A to, to show the documentation for COVID-19, as well as for human trafficking and intimate partner violence and PrEP management. And then there's 2 corrections that have been applied, and this was from found from 2019 reporting. The first one is for table 4, line 21, permanent supportive housing was a new line that was added for 2019, but the report did not have that line added. So now you will see that line on the report. And also for Intergy, the version that we're on also has the status available. So that way you can assign permanent supportive housing as a homeless status on your homeless patients. And for Table 6A, dental services section, line or the emergency services services are currently being reported to line 28 instead of line 27. So that has been corrected. And really the most change for those who might be running the CQM reports out of from the clinical dashboard, in version 12.15, that dashboard is removed. You will no longer have access to the CQM reports in PA, practice analytics. But they're not being gone entirely. Greenway is basically moving the clinical dashboard to a whole new platform called Greenway Analytics. And this is a more robust, analytics system. So that's more of the future regarding dashboard. So I'm sure there will be more news to come regarding Greenway Insights. Okay, so here I just wanted to give you a preview of what the UDS dashboard will look like. So the list is just a little bit longer with the 3 new measures that have been added. But where you get to accessing the UDS dashboard remains the same. Okay, so on to UDS 2020 changes. So we're very familiar right now with what has been added to 2020. HRSA released this information earlier on in 2020. I think it may have been around the mid-year mark when they had shared the approved changes. So as always, they'll continue to update the aligned quality of care measures that you see on table 6B and 7 with the ECQMs and so that has been updated for 2020 reporting. And as I mentioned before, 3 measures have been added: breast cancer screening, depression remission at 12 months, and HIV screening. 1 measure has been retired, and that's the asthma one. And then a change was made to the HIV linkage to care measure with the follow-up treatment timeline. And the new data collection lines that have been added to Table 6A for PrEP, for human trafficking and intimate partner violence, and of course for COVID. So for the approved changes for 2021 in the PAL document 2020-07 that was released October 21st of last year, not as many changes as you could see compared to reporting year 2020. So again, continued alignment of the CQMs or the quality of care measure reports with 2021 reporting specifications, and just continued updates regarding coronavirus. So table 6A will continue to be updated with any new codes, ICD-10 codes or CPT codes or testing. That will continue to be updated. And then a funding line has been added to the financial table 9D and 9E. And then just a question added to the appendix section in other data elements. If you have not seen or received the link to this PAL, the link here is provided. Okay, so now we're going to talk about setup and workflow of the clinical tables of 6A, 6B, and 7. So first I'll talk about where what are the key setup areas, and then the second half, and this is pretty much the majority of the time that we'll be spending during this presentation. We'll talk about what the measure, about the measure, and what areas of the EHR or what are the requirements for the denominator and numerator. Okay, So I definitely recommend, once we get to the workflows portion, please feel free to have any of the documents out, like the UDS manual, or even you could open up the Greenway document, their UDS user's guide as well, and that will give you some additional insight as I cover the information. Okay, so here, this is for energy customers. So the key areas for UDS are actually in both practice management, but majority of it is in the EHR system. So from the practice management side, the procedure code maintenance is an area that we will talk about, and then the rest are all EHR, which includes the vaccine setup, immunization setup, and there's LOINC mapping that does impact the reports. As far as area of documentation, as you can see here, the data elements are pulled from encounter findings, the problem lists, lab results, the prescription module, the OB module, and the immunization module. Okay, so the procedure code maintenance. Now, the reason why I have this screenshot, and you're probably wondering, especially, because, clinical staff generally do not go into this area of the setup because this resides in practice management. And I'm sure, your energy administrators or your billing administrators, this is where they would go if they want to add new procedure codes. But what's important to know is that in the procedure code maintenance, the UDS visit or the UDS flag is what tells the report to look for this code. And for most of the clinical reports, they have their own visit criteria that they follow outside of what the visit definition is for the UDS universe. So it's very important to know like what are those visit criteria, and of course to make sure that that code has this UDS checkmark flagged. Okay, so on to more, clinical in nature. This is for LOINC mapping. Now, this is the lab information window, and this is pretty much where all of the labs, like new labs, lab orders, results all come in here, and this is where the lab catalogs are set up. So what I'm showing you here is where is the LOINC mapping. The top portion of this window are all the different LOINCs, and the mapping, it occurs to the test component of a test. So this is really important because, Quest, LabCorp, they have different test codes, but generally what's the same is the actual test component might be labeled differently. But what makes it the same is that you can associate a specific LOINC code to that component. So that way for reporting purposes, or if you're creating an ad hoc report or even something like the UDS report, then it's easier to identify that the test should be, what qualifying test results should be used. So as far as what tests or lab results are looked at or requires LOINC mapping, and we get this question a lot, in support and in system optimization, because not every test needs to be LOINC mapped, but so you should only want to LOINC or make sure that the LOINC mapping happens. If you're just really thinking in terms of UDS, you want to make sure that your HIV tests, are LOINC map, the diagnostic tests, like what I have listed here for table 6A, HIV, Hep B, Hep C, the PAP or lead test, those for sure need to have a LOINC mapping. And then for the clinical measures on table 6B, like the cervical cancer screening measure, looks at or uses PAP and HPV as qualifiers. And the colorectal cancer measure looks at FOBT and FIT DNA as numerator qualifiers. And then the IVD measure looks at the LDLC result to qualify the patient for the denominator. And then for table 7, the diabetes measure looks at the A1C result level, to determine if it's controlled or not. So you could see lab results and like mapping is really important. So on to vaccines. So setup as well as schedule design is really helpful on, I guess, in meeting and helping kind of like document in the EHR so that way compliance can be met. So to get to the immunization setup, you would click on the Energy EHR button at the top and then down to setup, then over to immunizations. And then here you have the window for the setup where you can set up a schedule or maintain a schedule. And here you could also add vaccines, and that's under tools. So here's just a visual of a pediatric schedule. What's important is that you should have, at least for UDS purposes, you should have the 10 vaccines that UDS requires, which is DTaP, IPV, MMR, Hib, Hep B, varicella, PCV, Hep A, rotavirus, and flu. And the dosage requirements should also be updated and verified as well to make sure that all of the dosage requirements to meet the regulatory reporting specifications are there. But also they align with the CDC recommendation as well. So this is pretty much, so this sample template is designed based off of the CDC recommendations. So for the vaccine setup, the most important element that the report looks at, and I'm sure a lot of interoperability interfaces look at, is the CVX code. This is what tells different systems or interfaces, and of course the reporting, that this is how they identify the vaccine. So it's really important that when you're doing vaccine setup, that you know what the CVX codes are, and you have to make sure that it's correct. You don't want to associate a CVX code that belongs to an adult formulation to a vaccine that would be administered to a child. We've seen that with, I believe it was with Hep B or Hep A. So these are, areas that should be avoided. The next slide is actually a link to the CDC website. This is actually a link that I have as one of my favorites. This is a resource that I go to just so that way we could verify, what are the correct CVX codes that we should have added to the vaccines. And this is also a great source if you're looking for knowing what the CVX codes for other vaccines as well, like, for COVID. Okay, so now we're on to the section of where data comes from. We'll start with table 6A. Now, table 6A does not have any measure requirements like table 6B or table 7 does, but it is still important because it gives you at a glance the different services or diagnoses for your patients. These are visits that occurred, and so this gives you an idea like how many patients did you see for HIV, or now the focus is data collection for COVID. So this so this table gives you a great idea as to the types of services that you're doing, or what diagnoses that you're treating. Okay, so for the first section, which is selected diagnoses, so from lines 1 to 20D, all of these lines are looking at the diagnosis codes. And so right now, the report is pulling the information from the EHR, specifically the encounter note finding. Now, we've had several questions earlier on when Greenway had, made a change from when their previous report in energy would pull from like charge records to the transition to all of this information pulling from the EHR. And there was a lot of, challenge made because, what is being done in the EHR is not reflected in the charge record or vice versa. So, so I think this is, I think now, now that we are becoming, now that we keep promoting about the workflow, I think now there's more alignment, with what is documented in the EHR is now being reflected the same way over in charge records. So what is important to know about, this section is that the diagnoses would need to be documented in the assessment portion of the encounter note. So for the new sections that have been added to Table 6A for COVID, the first line is 4C, and this is looking at, patients that you saw for, treating the COVID problem. Again, this is all being pulled from the EHR system and encounter note finding. So if you are, searching for the diagnosis U07.1, and then that is then documented in the assessment section of the note, then that patient will then count towards this line. And similarly for line 6A, which is looking at acute respiratory illness due to COVID. So same thing, any of these diagnosis codes that you're searching in the medicine dictionary and then documented into assessment will then count that patient to this line. For the new lines, human trafficking and intimate partner violence, again, it's looking at the medicine findings. But for this documentation, we've made an update to the HCN quality measures form where we added the findings to a dedicated Table 6A tab. So you could see here, the screenshot on the right, this is from our HCN quality measures form, and this section is available. We had made this release, I believe, around September, in the September release. So you have this. Now, it only resides in the HCN quality measures form right now until we may decide to kind of move it to a different section that might be more appropriate, maybe like an adult visit form. But right now, because of the requirements for UDS, this is a place where you can document, these diagnosis codes, and it's in quality measures, so it's kind of like a one-stop shop if the focus is for, regulatory reporting. Okay, so the second half of Table 6A is selected services rendered. Now, the lines that you see here are made up of diagnostic tests or screenings or just services, preventative services. So it's a mixed element here. Some of the lines are looking at LOINC or medicine IDs, or some of the lines, like line 24, is strictly looking at the CVX code to identify that the vaccine occurred. So just, refer to the Greenway help document or the user's guide that I shared with you if you wish to know what the actual findings are. Okay, so added to this section for selected services rendered, this is for COVID and for PrEP. So line 21C is looking at the diagnostic test, and 21D is looking at the antibody test. So right now, these to count the patients and the number of visits to these lines, the report is looking at the corresponding medicines that are associated to these CPT codes. Now we do have a, you're probably wondering, well, they're tests. Why are they not associated to LOINCs instead, like some of the other lines? Well, that is a great question. I mean, when we saw that they were going in this direction and using medicines instead, we did submit on your behalf a change request to Greenway, recommending that they consider using LOINCs instead, because this is where these tests are being submitted. It's in the lab module. So it would make more sense that LOINCs would be used to identify that these tests occurred. So for now, in version 12.15, the logic is looking at medicines, but I am hoping in future, in maybe a hot fix, that the LOINC codes will be a qualifying element instead. So for the other new line added, 21E, which is PrEP management, there's a mix of data elements that this line looks at. The most obvious one, because you're prescribing, PrEP medication, the report will look at RX norms to qualify. But also with PrEP management, it could also be done with, counseling or an initiation visit, and that is identified by way of medicines. Again, for a full list of what the qualifying codes are, please refer to the PA help or their UDS users guide. Okay, so the last section is the dental services section. And this is the only section where charge records are looked at. What is important to know is that these dental service codes, they also need to be flagged as UDS, like the UDS visit flag, in order for the patients and visit counts to reflect here on this line. And also when posting the dental charge records, it's important that those charge records are associated to qualifying like encounters. They can't just be a blank, like the encounter field cannot be blank. You need to associate an encounter there in order for this to work. So for those centers that are have like a DFT interface with Dentrix, then I think this process is much easier, and you'll see that reflected in energy without any additional effort. Okay, so I just wanted to provide you with an example of how what the report looks at in terms of EHR data. So this is an example of line 9, diabetes mellitus. And in this example, a patient was seen on a May 21st visit. And you can see here that the diagnosis of type 2 diabetes with diabetic neuropathy is in the assessment section. And you can see how that diagnosis code is mapped to the qualifying medicine code 315281. Okay, so in another example, and this is with the seasonal flu vaccine for line 24A. So in this example, a patient was seen in January 4th. The flu vaccine was administered. So you could see how the CVX code that had been 141 that had been set up to the flu vaccine is a qualifying value on the data list. And this patient would then be counted to line 24A. Okay, so now we're on to talking about the measure and the workflows for the reports that are on table 6B. So what I have here, as far as, in the slide deck, I'm only describing the measure, but I'm not going into detail as to what the denominator and numerator specifications are. So, please feel free to, have the UDS manual open, and you could just tab to that section if you want to kind of read what UDS says, and then that might be easier when, as we're talking about where in the EHR, this information should be captured. Okay. All right. So, so the first measure on table 6B is it's the prenatal patients section. The first section A is about the prenatal patients, the age, and the second is the trimester of entry. So for both, it's looking at the OB chart and the registered pregnancy to determine, that this is a prenatal patient, and then it pulls all of the different elements like the date of birth, as well as, the initial, prenatal visit for the second part of the report. So here, just focusing on trimester of entry, you would then register the new pregnancy, for when the first OB visit is to occur. And then you would enter minimally. I mean, there's more information, especially if you're providing prenatal care for your patients. Of course, there would be more additional information that would be filled out, but just minimally when you're registering the new pregnancy, the information that is needed is the LMP. And then, of course, you would then check the initial visit now, and then boom, those are, the elements in which the report looks at to determine, which trimester of entry the patient will report to. So for 2020 reporting, there was a change that was made where now for the trimester of entry, the change is to use the first day of the last menstrual period. Okay, so just a slight change in specifications here. Now, for health centers who refer out the prenatal care, the workflow is just slightly different, but the area is still the same. You would still use the OB chart if you're wanting to use the dashboard report. Some health centers may choose to just, document on paper. Obviously that option is fine, but if you choose to want to document in the EHR, then the workflow would be where you would, once you've confirmed that the initial visit happened with the referred provider, then you would come here to register the pregnancy. Now, the first thing when you try to register the pregnancy is that you have to create an encounter note. The date of that encounter note needs to be backdated to the actual date that the first visit occurred with the referred patient. So a lot of this documentation that you'll be doing will likely be after the fact, on what if you're referring the patient out. So really the most important thing is to make sure that the tracking encounter that you generate has the date of when the visit occurred. And then all of the information minimally that you would fill out is what you see here on the screen with the LMP. You may want to enter a note here in pregnancy notes that this was referred out and who that prenatal provider is. And that's great for just auditing purposes. Okay, so for the childhood immunization status, now we know that the immunization module is being used. So what's important is if you're documenting like vaccine history, you want to make sure that after you select previous history from the selection, you want to make sure that the actual date of that dose is keyed in, not just select previous history and then save the record note. You actually have to key in the date as well, and that is what the report will look at. For administering, the administered, you can see the difference here, like in the example of Hib. You want to make sure that the vaccine administration happens before the child turns 2. And the immunization detail is great because it actually shows you the actual age when the immunization occurred based on the date. So you just want to make sure that it's before 2. If it's done on 2, the report will not use those records. Now, there was a change made for 2020 reporting in terms of the required vaccines for Hib. So before Hib, it only would take you would only need to do like a 3-dose series to qualify. But now that the formulation has changed with Hib, and so now it's either a 3-dose or a 4-dose series. So I think when after the upgrade, we might see some patients get dropped from the numerator because of this change in logic and requirement. Okay, so the cervical cancer screening measure. So we know that this measure is looking at pap smear as well as HPV to qualify for the numerator. If a patient has a documented hysterectomy, then of course they're just removed from the denominator. And it's a full hysterectomy, not a partial. So that would have to be documented in counter note finding. But for this particular measure, I guess the first source of data that is looked at is the lab result. So here is just an example of the test and how it looks with the LOINC mapping. Later on in this presentation, I have just a validation tip on how you can go about setting up your view so that way you could see if the test component is mapped to a LOINC. At least that way, then you could see, oh, it's mapped, but it might be mapped to the wrong LOINC. So now you can determine that an update or correction has to be made, and this is why the patient didn't fall into the numerator. So I wanted to talk a little bit more about what's going on with Quest Diagnostics. Now we saw this a change to this measure, after we upgraded to PA12, and the compliance, had changed, had dropped because the report logic is looking at the lab result field. It has nothing to do with LOINC mapping. It actually has to do more with how the data is being returned back from the vendor. In this case with Quest, they're not passing a result. They're leaving it empty, and they choose to pass the result in the comment field. So, in the previous version, the logic was simply looking at the LOINC, but now the ECChem specifications literally does say that the result value or result field cannot be null. And so this is why the, Greenway had programmed, or had coded the logic, the measure logic this way. So this is still a challenge. In version 12.15, there is not a change to what the report is looking at in terms of the PAP result value. It's still looking to expect a value there. But our conversations, our dialogue with the different entities, with like Quest, with Greenway, even with CMS, is still ongoing. So more to come with that, as far as what will occur. Please let me know if you have any questions, and we could do some follow-up if you have some concerns about the outcome of this measure. So for history, you can document in the quality measures form that the patient had a history of PAP or a history of HPV. What's important to know about this is that the date of the test needs to be entered in this format that I'm showing here, day, year. So we found examples where staff had just simply entered, the year or the number of months or days. The report is not going to use that as an onset. It needs the full date. What the report is doing instead is then using the date that the encounter or that finding was entered, and using that in terms of, to determine, if the patient should qualify or not. So that could be an issue, especially if you're, if you're looking at history, because it might skew the result or the report outcome. So definitely ensure the staff knows to enter the full date that the screening occurred. And you know what, same goes for the exclusion. You have the ability to document the hysterectomy here. So same rule applies when entering the date of the exclusion. Okay, so the breast cancer screening, fortunately, this was an area that we already had on our quality measures and clinic team forms. So as far as knowing where to document or just beginning documentation, it had always existed. So again, same rule as what I shared with cervical cancer screening. For history, enter the full date. Okay, for childhood weight assessment and counseling for nutrition and physical activity. So what's important to know is that weight and height would be recorded in vitals, and then documentation of counseling for nutrition and exercise would have to occur. Okay, so this measure is certain aspects of the activities that we do for this measure is allowed for telehealth. So let me just explain, what should be done. So the measure is looking for that, BMI percentile, like the height and weight is documented on a visit. This would have to be a face-to-face visit. Can't be self-reported. But the counseling portion, that can be done, it doesn't have to be done on that visit, though it's fine that you do, but it can be done on a telehealth visit. And that is allowed, that is allowed by UDS. So just keep that in mind as far as, considering it's a telehealth visit, or any type of patient engagement. I think for the most part, this measure is very hardwired, as well as some of the other measures that talk about screening. So they're generally being done, on the visit. So, but just be, cautious, especially if you're having a telehealth visit. Self-reported height and weight is not allowed. It's different than, the blood pressure measure. But if you already had recorded weight, height and weight on a previous visit that occurred during the reporting period, and you want to recommend different counseling, then that is allowed as well. The report will pick that up. Okay. Now, one thing to measure as far as the form itself, we do have a finding that talks about reviewed body mass index percentile. That is not needed for UDS reporting, but it is good for HEDIS. So continue, marking that off as part of the workflow before, and then go on to just selecting nutrition and physical activity. Now, regarding pregnancy is an exclusion on this measure, as well as some other measures. You can document it here on the form, but you do need to copy it to the problem list. Also, in terms of pregnancy, if you are providing prenatal care and you have registered pregnancies, please make sure, after the pregnancy is over, to close out those pregnancies, because the report, starting in version 12, will look at an open pregnancy and consider that as a pregnant patient, and that state will be that status will then count or remove that patient from any of, as an exclusion from some of the measures. So just be careful about that. Make sure that pregnancies, once they're done, that they end up getting closed out. Okay, so for the adult BMI screening, again, the workflow is very similar. Record height and weight and vitals, and then go here to the form to document BMI follow-up if the BMI is above or below normal. Okay. So the change that will happen to this form, not having to do with workflow, but more like form design, is that additional findings will be added to the follow-up BMI below normal section. In version 12, there are less qualifying findings available for below normal. So that's why you only see just one here. And there was obviously a lot that would qualify for above normal follow-up. So, so we're working on adding more elements to the below normal section, and that will be available in the January content, clinical content update. That will be rolled out later this month, at the end of the month. Okay, and same thing, you know, with documenting pregnancy. Make sure that you copy that to problem. But if the BMI was not performed due to patient refusal or any, you know, other reasons, like, you know, an emergent reason or situation, then that can be documented here using selecting one of the items from the dropdown, and then that will remove the patient from the denominator. Okay, so on to tobacco use screening and cessation intervention. Again, this is another hardwired measure. This is one that a lot of our health centers do well at. There was a slight change to the logic that was introduced in version 12, where it is looking at assessment of tobacco use in addition to the assessment outcome, tobacco user or non-user. So fortunately, we didn't have to make a change to the form because we already designed our forms this way to include assessment of tobacco use, and that was because of I think it was because of HEDIS, or it was because of some other, you know, requirement. But again, that's why I've outlined step 1 and step 2. First, make sure that you check assessment of tobacco use, and second, what was the outcome? Tobacco user or non-tobacco user? And if it is a tobacco user, then cessation, you know, would need to be provided either in way of counseling or pharmacological therapy. So in version 12.15, some additional findings or medicine findings are made available. So we will make sure that our forms, or at least for this section, does include any of those additional findings that are now, you know, that are now qualifying values. Okay, so for statin therapy for prevention and treatment of cardiovascular disease, so this particular measure, this was added, I want to say this was added for 2019 reporting. And for the most part, I think documentation for this measure is just happening. So this measure looks at 3 different populations. The first population is patients 21 years or older who have an active diagnosis of ASCVD. Second population is 21 years and older who have an active diagnosis of hypercholesterolemia. And then the third population is those patients 40 through 75 with an active diagnosis of diabetes. So all of these problems can be documented on the problem list. And then that will, you know, the patient will then count into the denominator. Now the problem list can also, is where you would also document exclusions. Now this would be, you know, pregnancy state, or if the patient is breastfeeding, or after diagnosis of rhabdomyolysis, or if they have ESRD or liver or hepatic disease. So that will then, you know, that documentation on the problem list for those events will then remove the patient from the denominator. Now, the denominator criteria also looks at additional elements, and this would be documented in lab results. So for population 2, apart from the active diagnosis of hypercholesterolemia, if their LDL-C result is greater than or equal to 190 milligram deciliter, they're in the denominator. Or for population 3, if their LDL-C result is between 70 to 180 milligram deciliter, then that will qualify them for the denominator. And then lastly, the numerator is pretty simple. You just would have to prescribe, statin therapy medication. So for IVD, use of aspirin or another antiplatelet, the denominator criteria is simply looking at an active diagnosis of IVD or AMI. For the AMI diagnosis, they look at whether it was added 12 months prior to the measurement period to qualify. But both of those diagnoses are documented in the problem list. And for the numerator, patients who receive a prescription for or were given, and this is why reported medication, is also looked at, aspirin or another antiplatelet, that will qualify the patient towards the numerator. Now, prescriptions of anticoagulant medication will exclude the patient from the numerator. So for colorectal cancer screening, the patient is automatically in the numerator or the denominator because of their age, unless of course there's exclusions that occur where they're, and that would be with, if they have a diagnosis of colorectal cancer. But as far as the numerator criteria go, there's many different ways to satisfy or for the patient to report to the numerator. The most common would be an FOBT test that is done during the measurement period, or a FIT DNA test that is done during the measurement period or 2 years prior. I'm sorry, there's a mistake with this slide. I meant to, this is all for lab results, so I apologize. The documentation for colonoscopy, which is during the measurement period or 9 years prior, can be documented on the encounter note. Just remember to include the full date in order, and the report will use that information. Be careful. We had seen some documentation where staff either was using a favorite or was documenting here, but they were adding some additional, they were annotating that the screening wasn't done, and they were either using this form or somehow they were using the medicine finding that the report looked at, but then because they were adding annotation of not done, the report doesn't see the annotation. It just sees that the medicine was documented. So then it was then counting that patient towards the numerator when in fact a colonoscopy was not done. So be very instruct staff to be careful. If the screening did occur, then you want to document. If the screening didn't occur, then do not document it here on the quality measures form. Okay. Now, for FOBT and FIT DNA, those events you're going to see in the lab results. Again, LOINC mapping is important here for those tests. All right, so HIV linkage to care. This measure was revised, as I mentioned before. The follow-up treatment timeline used to be 90 days, and now it's 30 days from first time diagnosed. So for the patient to be counted in the denominator, the diagnosis of HIV, B20 or Z10, would need to be documented there in the problem list. Just be sure, if it's not a first-time diagnosed, that the onset date is changed to reflect when that patient was diagnosed. For the numerator, the report will look at if the follow-up or the care, the HIV care occurred, and it will look at on the same day as the diagnosis or in a subsequent visit. You just want to make sure that if care is being provided by your facility, by your health center, that you document the HIV problem in the assessment. In the event that like follow-up treatment occurs, maybe at an outside facility, a change will be made to our HCN forms to allow that documentation. We had removed it because the report was not using those findings, but now for version 12.15, the logic has changed to allow looking at the qualifying medicine to indicate that HIV follow-up care did occur at another facility. So we'll be adding that back, and that will be in the January content release, the end of the month. Okay, you just want to make sure that when documenting that the HIV care had occurred from another facility, that that this occurs within 30 days. And make sure that it's really important that the date is fully entered. The date format is followed in order for that documentation to count towards the numerator. So here is a new measure for HIV screening. Patients who are age 15 to 65 at the start of the period will be in the numerator, I'm sorry, the denominator. Patients will be excluded from the denominator if they have an HIV diagnosis, and that's in the patient problem list. The report will look at, for the HIV problem, it will look at the date, beginning date and time that occurred prior or during the reporting period. And so if that documentation occurs, then the patient will be removed from the denominator. But as far as meeting the numerator, HIV test performed is looked at. And so for this measure, it's looking at rapid serum or plasma test to qualify. Okay. Okay, so screening for depression and follow-up plan. Now we saw a big change to this measure after we upgraded to PA12. Now, if you recall, the reason why this change had occurred is because the 2019 specifications, now this is an aligned measure to ECQM, and the specifications for ECQM stated that documentation of the screening using an age-appropriate tool was needed, and then what the outcome of that screening was, and it's simply whether it was negative or positive for symptoms. And if the screening was positive for symptoms, then a follow-up is expected. So we're very familiar with the follow-up portion, but the change in workflow that we had to implement, like mid-year, basically, was the additional, findings for recording that the screening occurred using an age-appropriate tool. So you could see here in step 1, these are the elements that we added to the PHQ-9, the PHQ-A, and you could also see it on the depression plan follow-up tab. So when a depression screening happens, you would obviously check yes, depending on the age. So that way it would then document that the screening occurred. And then on that same tab, like if you're on the PHQ-9 or PHQ-A, you can then, document the follow-up after you've documented the score. And so now it's only looking at documentation of negative or positive. If it's a negative screening, then that's all you have to do in order to meet this measure. But if it's positive, then of course, there's different documentation that you could do for follow-up. Now, this section on this form, we've designed it to give you a lot of different options that you can choose from, but you need to at least select one item. It could be one or many, but you have to at least select one if follow-up is to be documented. Now, there is a section on the current form that is age specific. We will be making a change to that design because there are some additional findings that are allowed that are not age specific. So just to make it easier for knowing what to select, we're going to make a slight redesign, and we're wanting to roll that out for January as well. So more to come. It's going to be easier to document follow-up if that is the case, and not have to worry, oh, is it age specific just for child, or can this be used for adults as well? Now, another thing to be aware of is that the measure criteria changed slightly, where it is looking at a screening. It is allowing a screening that occurred 14 days prior to the visit. So I'm hoping that this criteria might make it easier to meet this this measure. Now, as far as exclusion, if the patient has an active diagnosis of depression or bipolar, which would be documented in the problem list, then that will remove them from the denominator. Also, if the patient on that particular visit refuses further screening, then that is, an allowed exclusion for that patient. But that refusal is only for that time. It will excuse that encounter from being considered, or for the report for looking to see if a screening occurred for that qualifying visit. Okay, so that's something to keep in mind when you're documenting, the exclusion or the exception. Okay, so regarding the new measure here, depression remission at 12 months, this is actually a very interesting measure because it looks at the population who are currently depressed or have a diagnosis of dyspnea. So really what this measure is looking for, and it's very specific. So let me walk through with you what the criteria are. Okay, so for the 2020 measurement period, okay, a patient will be counted in the denominator population if they had a qualifying visit between November 1st, 2018 through October 31st, 2019, where they have an active diagnosis of depression or dyspnea that overlap this period. So they could already have been diagnosed with these problems coming into this period, or they were diagnosed on that qualifying visit for those problems. And then on that qualifying visit, or on, during that period, a PHQ-9 was performed, okay, and the score was greater than 9. So again, this measure is looking at a PHQ-9 assessment. If you're starting with a PHQ-2 and then you stop there, then that is not allowed. It's only looking at a PHQ-9. Okay, so what this is, so the PHQ-9 assessment that's done with a score of greater than 9 during this period of time, November 1st, 2018 to October 31st, 2019, that is known as the index assessment or event. Okay, so then now, and that is documented, and this is why documenting the score is very important. And we had to make a change to the PHQ-A form to use a qualifying medicine that the report is looking at. But the PHQ-9 score, we didn't have to make a change. That has remained the same. So you need to document what the score is. And if it's greater than 9, then okay, the patient is going to then be counted into the denominator or the population. So now the follow-up assessment is then looked at. So for the follow-up assessment, okay, that occurs like within 10 to 14 months of the index assessment, it is then looking for the PHQ-9 score to be less than 5. And if so, then the patient will be counted into the numerator. Okay, now this measure does allow, does have several exclusions. The first is a diagnosis of bipolar personality disorder, schizophrenia, psychotic disorder, and pervasive development disorder, and that would be documented in the problem list. If the patient had passed away during, the I guess during that 14-month period after the index assessment, that will, then exclude the patient from the numerator and denominator. Or if the patient is in hospice or palliative care or in a permanent nursing home or is a permanent nursing home resident, and that is and those two events are documented by way of medicine findings. Okay, so those are the exclusions for this measure. Okay, so on to our last measure for table 6B, and this is the dental sealant for children between 6 to 9. So this is the only measure that is looking at charge records, okay? To meet the denominator, the child would have to be, 6 to 9 during the measurement period. And they had at least one dental or oral health assessment, okay? And there's very specific codes that the measure looks at. I think there's like 10 codes. So it's important that you know what those are and that they're being documented. And if that encounter was also posted with one of the risk codes, there's a moderate risk D0602 or elevated risk D0603. So just posting these elements on the charge record will then count the patient into the denominator. Now, for the numerator, the report is looking at the sealant code to be posted. It's D1351, and that sealant code needs to be associated to, one of the 4 tooth numbers for the permanent, first permanent molar. It's 3, 14, 19, or 30, okay? And that is all done in the charge posting window. Now, in the event that a sealant cannot occur, then you can post the exclusion code, okay? But only do this if the child has no permanent first molars that can be sealed. If so, for example, like let's say in the scenario where the child comes in on a dental visit and they only had, they had a previously sealed molar, and then they had 1 permanent first molar that already erupted, but 2 were decayed. Okay, so you want to go ahead and seal that permanent first molar because you're able to, and then that's it. Don't post the exclusion code. In the following year, if the child is still, between the ages of 6 to 9, and 2 of their teeth are already sealed and 2 are decayed, then that would be the situation where you would exclude the child. okay? So just keep that in mind. Make sure that if you have the ability to post a sealant on the permanent first molar, then do so. But if none of the molars can be sealed, then that's when you would post the exclusion. And that could be posted at any time during the reporting period to, remove the child. So if you're doing like corrective action and you're, just looking at the chart to make sure should this patient be counted or not, then the posting can happen after the, sometime during the reporting period. And then that will give you accurate numbers. Okay, so on to table 7. We are nearing the end. I'm gonna just go a little bit quickly so we have more time to cover the questions, okay? So for table 7A, deliveries and birth weight, it's looking at the delivery information. So this is where you go into the OB chart and you document the delivery. What's important is multiple birth, single or multiple, and of course the birth weight, and then the birth type. Make sure that that it's entered appropriately. And then on to table 7B, controlling high blood pressure. A diagnosis of hypertension I-10 on the problem list will qualify the patient for the denominator. There is a change made for 2020 reporting where it no longer looks at the first 6 months. So if this diagnosis was made anytime during the year, the patient is counted into the denominator. For qualifying for the numerator, if the blood pressure is less than 140 and less than 190, then the patient is considered controlled. So for the diabetes measure on table 7, now this is a negative measure, so you definitely want to have a much lower number of that's in the numerator in relation to your diabetic patient population. So for the patient to count in the denominator, an active diagnosis of diabetes that is added to the problem list will be looked at. And so then for the HbA1c result, it's looking for that it's done. And if it's 9 or if it's above 9, then the patient will be counted. If there is no test that is found during the reporting period, then the patient will then be counted into the numerator. So for those practices who have, like an A1C machine test that they can do the testing on, and they're keying in the results manually, please make sure that the collected date and time is entered, at results when the result entry is done by staff. Okay, so that way that result can qualify. Okay, so on to our last section, and then we'll go on to questions. These are just tips for successful reporting that I wanted to share with you. So everything that you really need to know, why the patient is counted into the denominator or numerator is all available in the details on the dashboard. So I encourage you to look at those details to understand, what the report is looking at. And also pay close attention to the different colors that you see in the details. When an element is showing in red, that means that it's not being used. Or when the record is showing in black, like I'm focusing on the date column here, then that means that that element is being considered or could contribute towards, the criteria. Also, in PA, you have an ability to create bookmarks, and you could use this to create an inclusion list. In the scenario that you would apply this for would be some of the measures are strictly looking at a medical visit, but in some cases you might have behavioral health and medical providers, the services that they're doing could be reflected with the same procedure code that is qualified. So in cases like this, you may have encounters that were rendered by a behavioral health provider into your, qualifying visits. So if you want to control, and strictly, make sure that the measure is looking at medical visits, then you would create an inclusion list of your medical providers and apply that to the measure. So that way you have a much more, your the amount of data that the report is looking at is more accurate and meeting the criteria. So here, I won't go through all of the steps, but you have the slide deck, and you can, certainly set this up if you wish to, implement this this bookmark. Okay, but it's really easy to do. Here's the setup that I encourage anyone who is looking at data, to validate for the quality reporting or regulatory reporting. I recommend displaying the LOINC cross-reference for the test. And it's really easy to do. You would start off in practice management, and you would enable, change your user preferences to display the cross-reference for lab test component code. And then you would set the value to yes for test components to show. Then you would go into EHR, and then you would enable your preference to show lab tests and component codes as part of description. Now, this setup is not something that could be applied globally. This is per user. So, generally, so that's why, if you are responsible for just validating the data, for these reports, then this is definitely the setup that you should enable. Okay, the last tip that I wanted to share has to do with the low birth weight measure on table 7A. So when you're just looking at this report in the dashboard and you see the summary, you may see numbers that are in column 1B, live births less than 1,500 grams. You see that the number there, but you don't see, exactly, what is, what makes up that number. So when you look at the details and you set the filter under type to staff delivery prenatal, look through, all of the records there to see, could there be any records where the weight is 00. Then that, the delivery happened, but the weight was not entered. So this is how you can ensure that the numbers that you see on this table is accurate, because you want less of a number for live births less than 15 compared to the other two columns. Okay, so last is resources. These are truly resources that I use when I'm looking at your UDS data. So I always have bookmark the link to PA UDS help. This you can look at outside of the dashboard. Then I always refer to the UDS resource page for any information or any trainings that they may offer to give me more insight as to what is it that UDS is looking for. And then the ECQI resource center is where you would go to understand more about the aligned CQMs, because everything is there as far as the specifications. And then they would link what are the value sets on VSAC. Okay, so you would need a login created on USHIC in order for you to get to the VSAC page, but then that is where the value sets are. So so if the logic is looking at, encounters, a certain kinds of encounters, then you could see based on the value set, what are those encounters. So these are just very helpful resources. Okay, now we're on to questions. There was a lot of questions that were asked. So I want to make sure that we have time to go over them one by one. I'm going to go ahead and just unmute everyone. And if you wish to ask a question, you can either raise your hand or you can go ahead and unmute yourself, and then you could certainly ask your live question. Okay, let me first go through the questions that have been entered in the question box. Okay. Okay, so this first question, okay, so this was asked about OB transfer. In regards to OB transfers into practice, the transfer box and the date of the actual first visit ever needs to be entered for the chart to be properly counted. Okay, thank you, Marty. I think that was more of a comment in regards to when prenatal care is transferred into your practice. And Marty is absolutely right. You need to make sure the transfer box and date is checked. Okay, there were several questions that were asked about the cervical cancer screening measure or the report itself. Okay, so I'm not sure how much was shared. I may have shared this individually, but in our conversations with Quest, we had asked them if they could come up with a solution. What solution can they offer in regards to, remediate the situation? Because the logic is not changing. It's still looking at the result value field. So what can Quest do to help with this matter? And so there was, they had suggested, okay, well, instead of actually sending a full result like negative or just something, they would say, okay, well, let me go ahead and send a C comment, in place of any result field where it's null. So we tested that idea. Now, there were some issues with this suggested solution, because what they could not do was pass this C comment notation for just PAP tests. They said they had the ability to pass this comment to any result value field that was empty. So this was going to cause a problem when you're looking at your lab flow sheet and it says, when it's blank now, you have the ability to kind of hover on the lab flow sheet to see what the result is. So when now a comment that's not actually a result is being passed, then you kind of lose that functionality. So we were testing this solution with one practice, and this was something that they recommended would really affect how users would use and see results in the flow sheet. It would actually create more of a burden because now you'd have to click into and view the details instead of just hovering. So this is why we did not continue with this idea, and we're back to discussing what is possible with what other solutions can they offer. Now, surprisingly, Quest is sending a result for HPV. They're actually sending negative, or they're sending maybe some other comment if it's not negative, but at least they're sending some type of value. So we're hoping that they could do something similar for PAP. So more to come on that. Now, a few of you have some questions about this, so I hope I was able to address it. Now, as far as workflow, I had what kind of workflow can be done in order for the cervical cancer report to show more accurate numbers and not be understated. The workflow that we're continuing to suggest is to record the history. That the PAP screening happened. And if you're looking for that workflow or you haven't heard of it yet, I will be more than happy to share that with you. And I'll include that in the FAQ documentation so you have it. As far as another another question that was asked. What solution will there be to remediate the PAP issue and obtain accurate report? Again, as far as remediating, what solution is, it's either the vendor, the Quest has the result, or CMS approves a change to the logic. So either way, we're working on, whatever options is available. Now, as far as obtaining accurate report, if you're able to just follow the alternate workflow to update the record, then that is an option. But I can understand that this might be challenging for the larger centers, and we're just not talking about 2020 reporting. But if a change doesn't happen, then we're going to see this issue continue into the next reporting a year. So I don't have all of the answers right now in regards to what are we going to do for making sure that the cervical cancer screening report is accurate. But I will ensure that we will continue to keep you updated, as progress is made. And we're here to help with any type of gap reports. And that is still an option. There was mention that a gap report was to be offered, and that is still something, that might still be considered, but more to come on that. So here's a question that was asked by Caitlin, and I may need you to clarify this a little bit more. You're asking if it would be great if we could type the date in the QM form for PAPS and colonoscopy. The current thing takes a lot of time. You actually can type in the date instead of using the little onset calendar. If you would just click in the field and then go down to the bottom, you can type in the onset date. I hope that addresses your question. Let me know if it doesn't. You can just send me an email if I didn't answer correctly. Now there's a question here from Marty regarding a PHQ-2 can't be used for remission evaluation. No, this measure specifically says a PHQ-9. As the fault for the assessment. Okay, so another question asked regarding the sealant measure. Does the dental assessment need to be during a medical visit, or could it be during a dental visit? This is all dental visit. It would be a dental visit in which the risk codes would be posted. Okay, so here's a question on table 6B, HIV. Does this include OraQuick as rapid HIV screening? Yes, it does. Okay, so another question regarding behavioral health psych visits utilizing 9921X or 9920X, counting and including as medical visits, potentially skewing the denominator. Yes, that's very true. And that is why I suggest for certain measures that specifically state medical visits, implementing the bookmark to create your medical provider inclusion list could work. I mean, that will work if you're wanting to kind of narrow the amount of data that the report looks at for the qualifying visits for that measure. Okay. If the comment regarding the date of 2/15, if that was for any solutions that we would offer for cervical cancer, we are going to try our best. This is, we understand that having the tools, having the reports that you need to, to reflect the work that your staff is doing is important. And so we know that there are some of the measures after we upgraded to version 12 that just just never, that does not look right. It's not a true reflection of what has been done and what has been documented. So we're we're having our internal conversations to see, okay, well, what can be done? What is possible? What can be done for the network that could be distributed? So there's going to be more to come. I don't have an exact answer that I could give you at this time as to what we will be offering, but know that we understand that getting the accurate data is really important, and we're definitely going to provide you with some more updates on that. Okay, last question, and this is for table 6A regarding the HIV test. Will OraQuick be counted? No, table 6A is currently looking at tests that are like serum tests, and those are the ones that are going to be counted. And actually, table 6A, the HIV tests that that line looks at is limited in which test it's looking at right now. We have an open request at Greenway to allow more of the current tests, like the 4th generation test, to be counted. So right now, when you're looking at that number on table 6A for HIV tests, it may seem understated. It is going to be understated until Greenway updates the LOIN codes to valid qualifying HIV tests. Okay, hope I answered your question. So it is 11:32, and I'm sorry that I've ran out of time, but I appreciate the questions that have been asked during this session. And I promise that we will go ahead and package this into a consolidated FAQ document, so that way you can review the information later. And of course, if you have any additional questions after the session, please feel free to email me, or you have 2 other teams here at HCN who also can help you with UDS reporting. So on the screen is my email and our email addresses. So please feel free to use these resources, okay? So thank you so much, everyone, and I appreciate your time on attending this session. After the session is over, you will receive a pop-up of a survey. It's just a quick survey. Please, if you are able to complete that survey, I would really appreciate your feedback on how we're doing. How are we doing with these types of presentations? And if there's any feedback that you'd like to share of how we can improve. All responses are appreciated. So thank you, everyone, and have a great rest of your afternoon.